Hello, everybody, and welcome to this webinar. We're going to be talking about myositis today, and I am joined by a perfect person to talk about this, Dr. Aggarwal. So we're really excited to be learning about myositis, and I want to focus on the types of myositis. But before we get into that, Dr. Aggarwal, can you tell us a little bit about yourself and
Mhm.
why you chose myositis as a specialty? What drew you to this condition?
Well, thanks a lot for inviting me. I'm a professor of medicine at University of Pittsburgh. I'm a rheumatologist. And honestly, for last 10 years or more, my mission in life is to improve the lives of the patients of myositis. So almost everything I do in terms of research, clinical, and education is about myositis. And then you asked, like, why did I pick myositis? Honestly, I picked myositis for the very reason I picked rheumatology because of a complex nature of the disease with significant unmet need. When I was, getting into myositis, I realized very early on that very little is being done in myositis or has been done in myositis, and I felt that I could make a difference in this disease area because of complexity, because of not many people are working in this disease area in terms of research and education, and also it's a high unmet need. There was no a drug approved for this condition when I started working on this.
Wow. Yeah. So you've seen a lot change over the years. So that's certainly one of them. Could you talk a little bit more about that in terms of what has changed since you started being involved with myositis and treating people
Mhm.
with the condition? And like kind of take us through like how many years has it been that you've been involved?
I've been involved almost more than 15 years now, but a lot has changed actually. The biggest change in last 15 years is we now have at least one FDA approved drug for one of the types of myositis. So it's a big achievement because we got FDA approval and EMA approval and Japanese regulatory authorities approval. And so it's an approved drug. And the more important of the approval is we were able to prove through a randomized controlled trial the efficacy, effectiveness, and safety of IVIG in dermatomyositis. So I think that has a big impact in the world of myositis because it wasn't that one study that proved one drug in one subtype of disease and led to FDA approval, but it opened the floodgates for other novel targets or novel drugs to come in and be tested in this disease. And I'm pretty sure we'll find over time more and more treatment for this condition. So I think that's probably the most important thing. But also, we've come a long way for diagnosis and recognizing this disease, subtyping, subsetting this disease with the help of myositis autoantibodies. So there have been a lot done in diagnosis and outcome measures as well. But I think the biggest impact is having at least one drug FDA approved, which led to other with clinical trials that are now going on.
Yeah, that's so important. I think the first FDA approved drug really paves the way for more and more to come in the treatment space. And we've been referring to that there are different types of myositis. Why don't we dive a little bit deeper into this? Can you give us an overview of those different types? And then, we can kind of learn the nuances between them?
Yeah, so there are many different types of myositis. It's about six to seven, depends on how you type them. The number one, I would start with dermatomyositis. As the name would suggest, it has dermato aspect, so that means it has a skin aspect. So it has a significant severe skin rashes, along with myositis, which is the muscle inflammation aspect. So it's called dermatomyositis for that reason, but has severe skin rashes and muscle weakness and muscle inflammation. Another type of myositis is called necrotizing myopathy. Now, this is a very severe muscle disease in which patients can have all of a sudden from being normal to be wheelchair bound within a matter of weeks with severely high muscle enzyme level called CK, and severe disability can happen in this disease. Another type is what we call as antisynthetase syndrome. In this subtype, the biggest problem that we face is interstitial lung disease because most patients actually have interstitial lung disease, lung fibrosis, which leads to significant mortality and morbidity and poor quality of life because of the lung disease primarily. Another type that was more popular in past but has now become less popular in a way is called polymyositis. So polymyositis, previously the necrotizing myopathy and antisynthetase syndrome I just talked about, was considered part of polymyositis. Now, because we have now recognized those two entities separate from polymyositis, the overall the number of true polymyositis patients have gone down. But polymyositis was the main category in past, with patients with muscle inflammation leading to muscle weakness and many other manifestations like arthritis, muscle pain, difficulty in swallowing, lung disease, and Raynaud's, and so on. Another one that I specifically would like to mention is inclusion body myositis. This disease is very debilitating. It leads to high level of disability over the years because there is zero, absolutely no treatment currently available for this disease. So once the disease develops, we see patients progressing in front of our eyes, and we are not able to do much. And that's very frustrating for physicians. For other types of myositis, at least we are able to do things with immune suppressive drug and other immunomodulatory drugs and IVIG. We are able to attempt and do things, and many times we are successful. Sometimes we are partially successful. Sometimes we don't. But with inclusion body myositis or IBM, we absolutely are. We have nothing to offer to our patient other than exercise. Now, exercise does work for all the patients. And another type of myositis I would say is called overlap myositis, which is overlap between myositis and other rheumatological autoimmune conditions such as lupus, scleroderma, rheumatoid arthritis, and so on. So those are the main types of myositis. But in the last, I also want to mention now this type of myositis that I'm going to mention is already covered within the previous categories, but I like to mention it specifically because of high risk of cancer associated with dermatomyositis and to some extent with polymyositis. And we sometimes call this entity as cancer-associated dermatomyositis or cancer-associated myositis because many of these patients have either been diagnosed prior with cancer or after the diagnosis of myositis with cancer, typically within a year, definitely within 3 years. And then also want to have a special mention for another type called anti-MDF5 antibody because these patients develop severe interstitial lung disease and many of them die from severe, rapidly progressive interstitial lung disease in matter of months. So I want to specifically mention this type as well.
And with all this, it must be hard to diagnose the condition because there are so many different types. What is the process with that? I mean, we've talked a little bit about the treatment and how it's quite limited in terms of all the different types and what's available for treatment. But in order to even get to that point of treatment, you need that diagnosis. So,
Mhm.
how is myositis diagnosed? And then how do you end up getting the different types of myositis within that?
Absolutely. So the most important thing about diagnosis is detailed history and physical. And by a trained doctor. That's the most important thing. By detailed history and physical, in most cases, we have a very strong suspicion about the whether we are dealing with myositis or not, because there are many other muscle diseases, there are many other skin diseases. So by detailed history and physical, we can actually tell that how confident we are about the diagnosis of myositis. Then we often would like to confirm the history and physical based diagnosis by labs. So we have labs such as muscle enzymes, autoantibodies that we typically do. After the lab, what we do is one of the two tests is typically done called muscle MRI or EMG nerve conduction study or electromyography nerve conduction study. One of the two tests is needed, not both, but sometimes we end up doing both. That really help us to almost confirm the diagnosis of myositis, and sometimes we just stop there. But sometimes we go to the last step, which is the most important or gold standard step of doing the biopsy. In most cases, you need a muscle biopsy. However, in a typical dermatomyositis case, a skin biopsy might be enough. Um, and then what we do is one other test that I will talk about called myositis specific antibodies or MSAs. Now these are very helpful in diagnosis because they are highly specific for the diagnosis. But we do them for many other reasons beyond diagnosis because it tells us beyond just the myositis or the type of myositis, also tells us what clinical feature are likely to present in this patient. How will this patient behave to a certain treatment? What would be a long-term prognosis of this patient? What would be a possible comorbidities of this patient? So these antibodies inform us a lot more above and beyond just the diagnostic confirmation. So we'll always like to do that, even if we are 100% sure about the diagnosis because we've done the biopsy, we've done everything, but we still feel significant importance of MSAs or myositis specific antibody.
And you mentioned comorbidities, and you've said a couple of them as we've talked about, but are there others that you want to bring up that people should be aware of that are associated with myositis and that we should be thinking of?
Yeah. So one of the major comorbidity, you can call it comorbidity or a clinical feature, I would rather say maybe, is of myositis is interstitial lung disease or lung fibrosis. And why is this specifically important is because our patients suffer from myositis and their quality of life is poor because of myositis. Their physical activities of daily living is compromised because of myositis. There are many symptoms, bothering symptoms, but they don't die of myositis. They die because of interstitial lung disease in those who have interstitial lung disease. So it's a most common cause of mortality and morbidity in our patients. So that's why we pay specific attention to patients who have interstitial lung disease. Now, fortunately, only 30 to 40% of our patients have interstitial lung disease. But those who have this is a real problem because lungs are important and patients develop shortness of breath and oxygen dependence and lead to lead to mortality in many of these patients. So we pay specific attention to diagnosis of this entity in myositis patient early on by doing CT scans and lung function. And upon diagnosis, we pay specific attention on how to treat interstitial lung disease in this entity. And there's not much done in this disease area, in interstitial lung disease area. We actually recently launched a clinical trial called Myositis Interstitial Lung Disease Nintedanib trial or MINT trial, in which what we are doing is, as you can imagine, it's a rare disease. So we are enrolling patients from anywhere in US from their home. So this is a trial where patient can participate from the comfort of their home by us sending them home nurses, by us sending them devices like a tablet to do questionnaire, by doing home lung function study, home blood pressure and vitals and other monitoring. So it's a very patient-friendly study because rare diseases otherwise doesn't get studied because of their rarity. So we kind of figure out a way how to expand and enroll patients across US.
And in order for patients to be seen, be able to have a diagnosis, potentially enroll in clinical studies like the one you mentioned, MINT, we need to be able to pick up on those symptoms ourselves to then bring us to a physician or a healthcare provider to help that diagnosis and start on that journey. So what should people be thinking about in terms of red flags, heads up of, okay, myositis may be a condition that's present in a person?
Yeah, that's a great question. So when patients have symptoms, it is very difficult for patient to figure out what they have. They have to rely on their doctors in most cases. But having awareness of there is something called myositis that can cause these symptoms would be helpful. So first of all, we need to increase the awareness. But typically the patient's symptom would be fatigue, muscle weakness, specific skin rashes. Sometimes they're present with arthritis, and sometimes they're present with just shortness of breath and cough because they have that interstitial lung disease problem that we were talking about earlier. So these are the common symptoms that the patient have. They have difficulty in getting up from a chair, going up the stairs, getting up from toilet seat, doing regular bathing, shower, and those kind of activities. So activities of daily living, they have become hard for them for because of the muscle weakness. They can have severe itchy, burning rashes. Joint pain bothers them. So all of these symptoms could be problem. Many patients have difficulty in swallowing because the upper part of the our swallowing apparatus is a muscle, a skeleton muscle. So that could also be abnormal. So these are the symptoms. But then they have these symptoms. They should alert to their doctor, and their doctor should run a basic battery of tests, should do a detailed history and physical. With the more education of the doctors, general doctor or general physician and primary care doctor, they should be then able to recognize the myositis and send them to a right rheumatologist, neurologist, or dermatologist. The problem that we see in community is that primary care doctors, general physicians are not well trained in autoimmune diseases and definitely not trained in myositis. So there's a significant lack of education in medical school, residency, fellowship, and all about these autoimmune rare diseases, specifically for myositis.
I'm a visual learner. I'm sure many of you are as well. So I find it's helpful to also see this written. So we figured we'd go over some of the signs and symptoms of myositis. And many of those can be fatigue, muscle weakness, skin rashes. Sometimes we're seeing arthritis, sometimes just shortness of breath and cough due to interstitial lung disease. That's what the ILD is. We can see that daily tasks can also be difficult. So getting up from a chair, going up the stairs, getting off of the toilet, being able to bathe yourself, all of these tasks that are often done independently, but people with myositis might have a difficult time in achieving these independently. And in terms of the rashes we talked about, these can be severe, itchy, burning rashes. We can see joint pain, also swallowing difficulty. So there's a lot of features that we can see that independently are pretty generic, but then once we start putting them together, it's a little bit more obvious that it could be myositis. But one of the key pieces to this is going to be having general care doctors be aware and educated about myositis so that they can group these symptoms together and recognize them as, in my differential diagnosis list of what I think could be causing these symptoms, I'm thinking myositis. So we need to be able to educate doctors so we can get to that point so that when these general practitioners, like family doctors, see this as, oh, maybe someone has myositis, they can then refer to a specialist to take it from there. Now, what does that look like? The steps to diagnosing myositis, we really need to start with a detailed history and physical by a trained doctor to then give us that strong suspicion of myositis. We're going to need to follow up with a lot of different types of information. So labs like muscle enzymes and autoantibodies, doing imaging with MRIs, nerve conduction tests. Sometimes we're doing both of them, sometimes just one of them. Looking at different biopsies. So sometimes that's the muscle, which makes sense with what we've been talking about. Sometimes that's skin. We talked about those rashes. So depending on the different type of myositis, what's going to be more appropriate there. And circling back to the antibodies, myositis has specific antibodies, which really helps with the diagnosis, but looking further from the diagnosis, it's really helpful to give us more information about the clinical features that are likely to present. So what are those symptoms looking like? How can we then help treat the patient in a personalized precision medicine way? You have these types of clinical features, so we want to focus on those. And looking at the prognosis. So if we can have a more specific diagnosis, we're going to have more detailed information about what is the progression of this disorder going to look like, and what are other types of comorbidities that could be coming up that we should be aware of and be talking about with people that may have myositis and preparing them and saying, hey, keep an eye out for this coming up. And again, for their healthcare providers to be very clued into this. And what are some of the unmet needs you think in myositis treatment? We mentioned that there is an FDA approved drug for one of the types. So I'm thinking not having FDA approved drugs for the other types, is certainly an unmet need. But can you expand upon that a little bit?
Well, even though we have one FDA approved for drug for one of subtype, but that's not enough. We know from autoimmune diseases that every patient is its own disease. Every patient is different. So this drug will work in a large number of patients, but will not work on many patients, or will work initially, but then will stop working because the immune system is smart. It can come through those drugs. So we don't need one drug. We believe we need 5 to 10 drugs for each of these subtypes to really get to a 90% patient population that we feel confident when they come to us that we will be able to treat them. To have those drugs available to us is the key. And that's a major unmet need of having drugs that are proven by a phase 3 clinical trial, proven efficacy and safety by phase 3 clinical trial, which then led to regulatory approval for those drugs so that those drugs are available in market for us to actually prescribe those drugs. So I think that's the biggest unmet need. There are a few other unmet needs like awareness of the disease amongst the patient and general population. If you ask 100 people on the street, have you heard of this entity called myositis? 99.9% people will say, no, I've never heard of this before. So not being even heard is a big problem for our patients. When our patients get diagnosed and they go tell their relatives and friends and family, they get like a blank faces. What are you talking about? What is this? We never heard of this, which kind of discourages them and to discuss their disease as well. Also, education of our doctors, general physicians, rheumatologists, neurologists, dermatologists needs to be better educated in these diseases so that they can recognize this disease early on and refer them to the right doctor for the right treatment. Now, IBM, for example, it takes about 10 years to get a diagnosis of IBM from the symptom onset. So there's a significant unmet need there as well. But I think the number one is still remains lack of effective and safe drugs.
And that's precision medicine. We want to be able to say this patient needs this drug, and that's the match that's going to work. And as you
Absolutely.
said, even if that drug is a match at that time, it may not be in the future because with autoimmune conditions, we can have the immune system, as you kind of
Hmm.
put it, learn and say, oh,
Yep.
okay, we're basically going to fight this and not have this drug work anymore. So I think it's even more important to have an arsenal of different medications that we can choose from and really personalize the treatment that we're giving to patients. So I think that is such an important part. What would you like to see most in change in this myositis treatment? I mean, we talked about the drugs and we talked about just the awareness on the population level, but also the healthcare provider levels. Is there anything else that you see that you really wish could be changed in the near future?
I think the biggest thing is to get more and more trials that are coming in a myositis be successful. And most of these trials suffer from one thing, which is recruitment. So I think we need to make more efforts for wider recruitment through innovative trial designs like decentralized trial like MINT and other studies because our patients need these studies. We want to do those studies to prove those treatment, but if we don't have enough patients in our center, how would we prove what we want to prove? So I think should change with a better, clever trial designs and decentralized model. And I think FDA and other regulatory bodies are coming at pace with it, saying that, okay, we do agree that this is a significant unmet need. We need to recruit for patients with rare diseases clinical trials so that we can prove what works and what does not work. In next 5 to 10 years, I would say I'm hopeful. I'm very hopeful because I know many clinical trials of very good disease drug targets are currently on way. These drug targets are what we believe cause the disease. So if we are right, and then these trials are successful, then we should have multiple treatment options for multiple indications in next 5 to 10 years. So I'm very hopeful overall for myositis patients in next 5 to 10 years.
It's a very promising time, I think, for a lot of rare diseases. And as you mentioned with myositis, that there are a lot of clinical trials that are ongoing that are really promising. So it's
Mhm.
it's encouraging to see. And I would love to know, what does a good day in your practice look like when you're like, that was a great day, whether it's patient interactions, kind of what that looks like for you and how you feel at the end of the day when you do have those
Yeah,
good wins.
I will tell you this that what makes my day is taking patient off treatment because they're in remission. And
That's a
I
good
will
feeling.
say, I would say, and that happens in myositis. Many patients we treat, we get them better. First we struggle, then we get them better, then we stabilize them, then we taper their treatment off. And the day when we taper the treatment off, now the drug-free remission is my goal. And when we achieve that, it's almost like you got to have a party. Even if I have one patient in a day where we're able to do that, that's a big deal. Another way I feel like very rejuvenated when I am puzzled and I have to go back and think a lot and discuss a lot. I had yesterday had a patient who totally stumped us with his symptoms, and I told the patient, look, I don't know what you have right now, whether you truly have myositis or not, at which type, but I can promise you we'll try to figure it out. And that also gives you a very good feeling that you are able to solve some problem, real world problem. So those are the two scenarios I think I would say give me a very positive feeling.
Yeah, that is wonderful. And you just do such meaningful work and working in with myositis patients for 15 years. I mean, that is just wonderful that you're able to provide this for so many different people. And you're such an expert in this area, as we've experienced, of you just educating myself and the audience. So thank you so much, Dr. Agarwal. It's really just wonderful to hear all of the insights about myositis. We've talked about the treatments, we've talked about the different types, how we diagnose. So this has just been really helpful.
Well, thanks for having me.